you have a special biopolymer. And so what happens is once this enters a landfill, this outside is going to get a lot of microorganisms that come in because it gets hot and wet and moist in a landfill. She's ready. And she's paying attention. And so what happens is, imagine this is in a landfill now, and that inner bottle is going to release a certain scent that attracts the microorganisms in this outside cardboard. And they're going to break down the bottle. So it makes a really nice biodegradable bottle. Thank you very much.
Well, hold on. Normally, a bottle takes how long to break down? How many years?
800.
And how long does it take to break this down because of the microorganisms and the scent?
Roughly 5.
5 years. So you're helping the environment by drinking this. Yeah. Thanks so much, my man. All right, Nick, take it away.
All right, excellent. Welcome to the 115th episode of Silicon Zombies, where we bring you the best brains from the Bay to beyond. That's right. We bring you awesome entrepreneurs and founders and scientists to demystify emerging technology, understand the science of scaling, and tell the stories that matter. Before we get into the 3 delicious brains that we have today, I want to do a quick shout out to our sponsors. Obviously, the Park James Hotel. Thank you so much. Gorgeous location. And also thrilled to have Nicodex as our sponsor. So if you're building any products, make sure to check them out. That's nicodex.com. We'll have their link in the show notes. And also Primero Negocios, which does all of our branding. Beautiful stuff. So thank you so much to them. Let's kick things off. We've got 3 incredible folks today. So we've got Raphael, who started a company now publicly traded called Eargo. And then we've got Dominique Kim, who runs the Healthtech Accelerator at Founders Institute. And of course, Dr. Marcin, he's a world-renowned cardiothoracic surgeon.
And is it true that he flew in just for this?
Sure, let's say that. And then also he did the world's first COVID lung transplant. So just rock stars on the panel today. We're going to learn about the future of medical technology. So before we get started, maybe we could do a quick introduction with our lovely panel here.
On? Yes, it's on now. Okay, hi everybody. I'm Dominique Kim. I live in San Francisco currently, but I'm originally from the East Coast, from Boston. I grew up in a healthcare family. My dad was an OBGYN, and I grew up very interested in healthcare. And to make my story short, I've worked in quality improvement in healthcare systems for more time than I want to age myself, but for quite a while. And I've pivoted over to health technology over the last 5 years because I really believe in the power of technology to help to drive value-based healthcare. And we'll talk a little more later about what that is. But it's great to be here, and thanks, Nick, for bringing us together.
I'll go next. I'm Raphael. Delighted to meet you all tonight. I live in Palo Alto, not too far. I grew up in France, in the French Alps, so I'm a big-time skier. Came here 20 plus years ago to go to Stanford. Never left because I fell in love with Silicon Valley, healthcare innovation, and I met my wife. So I had a good reason to stay. I've been a serial entrepreneur in health tech and healthcare for 20 years, built a few companies in a variety of spaces. We can talk about that a little more. You did mention Eargo. I'm covered in scars from having been in the trenches, so happy to share those stories, and really delighted to be here tonight. Thanks, Nick and Human, for having me.
Hello. Nice to meet you all. My name is Marcin Maruszweski, and by the name you can clearly say that I don't come from here. So I flew exactly 11 hours from Poland, and this is where I live and actually work at the moment. I've worked in a couple of places worldwide. I worked in Austria, UK, and I also have received the Stanford scholarship, so I was here before. So this is my background in terms of medical background. I'm a cardiothoracic surgeon by training, and basically, yes, what I do for a living is replace hearts and lungs in people. But that's everybody has to do something, right? So apart from that, I'm really excited about working in tissue engineering, in medical devices, and software engineering, because I think that this is the future of of medicine and healthcare sector. So that's basically what I'm here for, and this is where I came here to discuss the outlook of not only human transplants, but basically what can we do basically for humankind in terms of development and progress. So thank you for having me here. I'm sorry for the jet lag. It's only 9 hours, so it's 3 a.m. in my country right now, but I'll do my best.
Dr. Maruszweski is also the medical director for Untitled Kingdom, so super cool background. So let's get started. Obviously, things have changed quite a bit since the pandemic. What do you think are the biggest changes from your perspective? Raphael, let's start with you.
Yeah, I think that the pandemic was, a very, very tough time to go through. At the same time, it created new opportunities and it accelerated some trends, particularly with telehealth. So telehealth is not new, right? If you actually look at it, it was created probably at least a decade ago, if not more. But there was resistance to adoption and changing the way medicine is practiced that COVID changed. It became a necessity. And so it accelerated telehealth and I would say accessibility to health services that have been very positive because now people are comfortable, both providers and patients. So that's been great. I'd say as an entrepreneur, the other thing that was amazing with the pandemic is that investors became comfortable closing deals on Zoom, which before you had to fly wherever they were to meet in person because there was no way they were going to close a deal on Zoom, and now they're very comfortable actually transacting. So it's also opened that investor scene and accessibility to investors worldwide because you can use Zoom. Why not?
Yeah, I would just add to that, I think before the pandemic, there's a lot of talk about how things have changed during the pandemic for healthcare and new trends that have started. But to me, and kind of a little bit riffing off what you were saying, I think there actually are a lot of the same challenges and the same goals that there always were. I think the pandemic just accentuated that there's forms of digital health that are actually even more accepted and appreciated than we ever thought. I know having worked when the pandemic hit, I actually had just started a job at Blue Shield of California the week before. So I saw my office for 3 days and then was sequestered at home for the next few years. But we definitely were doing a lot at Blue Shield and a lot of other places to just rapidly accelerate the use of telemedicine. So what we and many, many other health systems learned was that you actually have a lot more patient receptivity to it. There's technical things, especially on the provider side, that need to be worked out. But at the end of the day, it gets kind of to the triple aim, which we'll talk a little bit about later. It reduces costs, it improves patient satisfaction, it improves access, and it actually can improve efficiency and quality of care as well. So there's a lot of ways that I think, reinforced that a lot of kinds of, particularly telemedicine, a lot of kinds of digital health are very beneficial in a value-adding system. But I think a lot of the other challenges, which we'll get to later, I think are even bigger than they were before, and we're still tackling the same problems that we were before. I'll talk more later.
First of all, I'd like to thank my panelists for bringing all the issues up before, because now I can build on that. It's much easier. Because I'm a surgeon, my English is very simple and straightforward. So I would call it with one word, which is trust. And this is from the physician's perspective, something that is a game changer, basically. We cannot imagine, and go back with your memories 5 years ago, would you ever contact your physician without seeing him, without being directly examined and getting some prescriptions, including the novel shots against COVID and stuff like that? So the trust has significantly changed the relationship between physicians, the patients, the payer, and the provider of technological solutions. And I think this is absolutely something new. And I'm great that we have built upon this trust, and we trust the new solutions and technological solutions. This hasn't been before. We were looking at it with a little bit like, what is this about, and what is this really this device providing, and is this really valuable? Now we trust them and we use them. And the scale of using the technological solutions is much faster and much bigger than it was before the pandemic. And this is what has changed, and this is because of the trust that has been built over the pandemic. We had no choice. We had to trust the solution.
You all mentioned telemedicine, and every experience I've had with telemedicine has been less than satisfactory. The doctor has always said, well, I can't quite diagnose that with you there and me here. I can't prescribe that over I think there's a lot of flaws with telemedicine. Am I wrong or am I right? I feel like I'm right. Can you address that?
Yeah, well, I think it comes down to what's the job that you're trying to accomplish with that service. And the job you're trying to accomplish with that service is give you the same experience and the same services than the ones you would get in a clinic or a hospital. And so through telemedicine, you do get access to a physician, and they do get a chance to see you, and you can talk with them. So that is there. But what's missing in a lot of cases is actually the equipment and the tools that they need to inform a clinical decision. And there's a big opportunity here, right? So, for instance, I've been on consultations through telemedicine and said, do you have a blood pressure cuff at home? It's going to be good enough. Can you just put it on and, it'll do because I have nothing else. Like I don't know what else to use. So if you actually think about the basic equipments, the basic sensors that are clinical grade and that are currently used in hospitals and clinics to formulate a diagnosis and to support a prescription, you don't have access to all of those in your home yet, right? The day this will happen, and it will happen, we'll have medical grade, wearables and sensors that will provide that information. That will unleash really the potential of telemedicine. I think we're at the beginning of it, and it's limited in services, as you were mentioning. It's still subpar.
Okay, great. Thanks for confirming what I think we were all, because you guys were talking about telemedicine, and I'm glad it accelerated, and I'm glad we have access, but it's so not where it needs to be.
Can I share an anecdote, just really quickly?
100%.
Because it's not working, but it's come a long way. I'll tell you Eargo. So Eargo is it's the first direct-to-consumer medical hearing aid company that was created, first company to go public in the US. And it was a very, very difficult company to build. The idea was to just reinvent hearing health with a better product, better solution, but also a better experience going directly to the customer, to the consumer, the user. And so we're shipping, and we still are, shipping you hearing aids straight to your home. But the thing with hearing aids is there's an adaptation period, and you do need some support and counseling from an audiologist. Otherwise, you're kind of set up for failure. There needs to be some level of human touch. And so back in 2015, when we launched, we had a telehealth platform with audiologists, and a lot of time, what was getting in the way of that onboarding is that people didn't know how to download the video app, the video calling app on their tablet or smartphone, or they forgot the password for the app store. And I think a lot of that has come around through, the pandemic and kind of getting on that train of I got to be able to communicate over video, and a lot of those services got a lot better in that sense. But we're still missing some tools.
I would just add to that we learned a lot from the pandemic. I know from, I was on an implementation team that was actually implementing and accelerating the use of telemedicine through Zoom. So we learned a lot, but the thing I want to add is the majority of problems were really technical, so I completely echo that. It was just actually getting connectivity and getting into the Zoom, and that was both on the provider side and on the patient side. And so a lot of those technical things I think have gotten better, but I think the deeper rooted issue is you're using telemedicine for a certain purpose, and it's not a standalone service. And so there's a lot of other kinds of digital health now that are kind of exploding, and I think it's an ecosystem of technology combined with people and processes that we'll get into a little bit later that's going to make telemedicine more helpful on its own.
Can we talk a little bit more about that? So if there's these remote patient monitoring devices, what is the next chapter? I mean, you must see a ton of that kind of innovation running the Healthtech Accelerator, Dominique.
Yeah, so it's funny. I don't really think of it as a next. I think of it as a adding to, almost like layers of an onion. And the hub of that has to be a coordinated approach. And it sounds kind of like pie in the sky, but there are systems out there. Kaiser Permanente is not the only integrated system that's using digital health. A lot of other systems are now, and CEOs and executive suites of systems are starting to get more open to the idea that they need to adopt digital health. and there's more and more out of cost necessity and efficiency need of that happening. And so I don't see it as telemedicine being replaced by something else, but more, I guess, joined by other kinds of technology like remote monitoring at home, primary care teams actually co-locating and being in the home. I have a friend that started a company, I won't name the name for just it's not here for that, but to bring primary care into the homes, particularly of low income, but also any income. So there's a lot of care at home happening. So as you can see, it's becoming this ecosystem where we have a coexistence of in-person and virtual care combined with remote monitoring, prescribing in the home, self-prescribing, self-dosing, sending the information back to your provider. There's so many incredible things. That's why it's so exciting to be in health tech today. So I don't think it'll be replaced, but it'll be definitely get better. Hopefully you'll have a better experience the next year.
Well, I'll say this. The one thing telemedicine does right, the one, is the wait time. I mean, they're right there. That actually is the best part about it. You schedule that time, you're not waiting in, the doctor's office for 30 minutes before they. So hopefully you'll build on that. Okay. To the doctor. First of all, thank you for coming all the way from Poland. In your expertise, what does America do wrong when it comes to medicine that Europe does absolutely right?
Give
Not really a fair question.
Give us your worst.
Well, since I was allowed by Homeland Security to enter this country, now I can take this. Yeah, well, let me share the European perspective with you, and I'll build on the previous questions that I have not responded yet. Well, one of the problems with telemedicine is that the patients have adopted faster than medical professionals. Because when the pandemic hit, patients were forced out of the system to be served at home while we stayed in the hospital. So we didn't have to adapt to the solutions. Now we are getting a lot of data, and who is processing that? We. How do we distinguish the garbage data from the good quality data? That's one of the reasons physicians, especially in America, are very restrained and very slow on adopting all those services, in which I understand. One of the reasons for that is also a little bit, I'm sorry, this is rusty English, retarded legal system here. Because the Medicaid regulation...
We understand.
I'm sorry, I mean, no offense, but Medicaid regulations do not support early discharge and home monitoring of patients. The hospital is not reimbursed for basically making the turnaround of the patient faster. The solutions are here on the market, but the hospitals are not allowed, or they are allowed, but they are not incentivized for the fact that they can bring the home care with the patient at home. So the patient will not stay that long. In the 1960s, the average hospital stay time in the United States was 13.6 days. It's not necessary now. Many procedures in minimally invasive surgery, also in cardiac interventions, can be done without an overnight stay. But Medicaid regulations have been written in 1960s.
So if we're trying to improve innovation and, Dominique, to your point, accessibility, how do we, obviously these monopolies have a vested interest in not pushing that forward, because that's creative destruction. That means taking dollars out of their pockets. So what kind of actions can we take to really bring these new innovative technologies so we all have access, so we all have better health and better medicine?
That's a good challenge, because from my perspective is basically seeking and exploring novel solutions to the health problems, right? I think we should basically all adapt the fact that in many situations we can have patients being taken care out of the hospital. The hospital is the ultimate place and the most expensive hotel in the city. It's not necessary for many patients. And patients should be treated this way, and if we show the benefit, also in terms of faster recovery rates, this is one of the ways we can approach and show by the numbers that patients benefit from that. If patients benefit from that, the payer benefits from that. And the wait time may be even slowed down because there will be no overstaying in the hospital, for example. And from my perspective and from European perspective and also from the US perspective, the hospital care is the most expensive one. So I would tackle on this one first.
Yeah, I think that there's policies that have started to be put in motion that are looking at the reimbursement system. And when I say started, I mean for the past 20 or so years that I've been in healthcare, we had pay-for-performance systems a long time ago, but I think they've caught on more, and they're a lot more cost-saving, or I should say attractive for providers to use them, because value-based healthcare now will reward clinicians for providing better whole episodes of care where your health outcome is better. So we're moving sort of in response to that problem of just having long lengths of stay and non-beneficial health outcomes to show for all the care we're giving these patients. We're now having policies that are turning into reimbursement best practices under the rubric of value-based care that actually reward for outcomes and don't just reward you for the number of things that you do, fee-for-service. Many of you may be familiar with that term. You're paid for every single service that you do. It's sort of like you're working on commission, right? And you help 5 people buy a sofa. You get paid for each sofa, basically, right? Healthcare, it's a lot more expensive than sofas. So you're spending a lot, and that's costing the economy. So I think back to your question, there has to be, value-based care isn't just a nice to have. It was essential because the results weren't happening. And what's going to happen? Healthcare systems can't go on like that forever. Many of them have gone out of business, and the bigger ones have had to change or die. So that's why Kaiser is kind of hailed, as doing good things, because they have been working at this value-based equation thing, and they are only paid if the outcomes are better. So that's just one way of thinking about it. The reimbursement changes behavior.
Did you want to add?
Yeah, I just wanted to take a slightly different angle because I love the answers are so pertinent and straight on point. But maybe the other angle is to keep patients out of the hospital in the first place. And historically in the US, a lot of the reimbursement has been focused on interventions, not on prevention. And it had a couple of issues. The first one is the incentive that it creates for providers to really focus on interventions, because they used to be paid every time they intervene. But also, even from a startup standpoint, an innovation standpoint, there was not a lot of enthusiasm from investors and VCs for companies that were working on prevention because there was not a strong business model. There was not a lot of money available from the payers in the first place. It's changing now, and I think it's changing thanks to the integrated payer providers like Kaiser that are removing some of the misalignment of incentives between payer and providers, but you're also seeing more and more self-insured employers. And what's interesting with the self-insured employers is that they're trying to achieve 2 things. 1, they're trying to minimize their healthcare costs, and 2, they're trying to maximize retention of their employees, and so they want to make them happy. And so there's now a shift towards innovation in prevention and keeping employees and keeping people healthy, and there's money being spent on that, and the equation works for the self-insured employers. And I think it's actually a very good evolution of healthcare in the US.
Did you give a complete answer to what Europe does correct and North America doesn't do right? Or is there a few things you're leaving off that list? Don't be shy. We're all friends here.
The other challenge I see is really financial constraints of the patients. Healthcare is very expensive everywhere, but the way patients are being supported here is a little bit minimized from my European perspective.
Can you give us a concrete example of something you've seen here that Europe does from a financial standpoint when you say it's minimized? Is there a certain procedure in particular you can point to?
Well, basically all of them, because because it's the system solution. It's not just procedures are expensive worldwide. We use the same equipment in Europe that is being used in the United States. There is no difference technically.
Let's tie this into the COVID lung transplant you did. In Europe, what was the cost of that, and what would you estimate the cost to be here? That you guys covered, and break it down for us.
Okay, well, The average cost of the lung transplantation in Poland and the reimbursement rate for the first month of stay, which covers everything, all the logistics, all the salaries, all the equipment that is being used, is under $100,000. Yes.
100,000 US dollars for the
Yes.
COVID lung transplant. Okay. And you guys covered everything in Poland?
Yes, it's fully reimbursed. The patient doesn't pay a dime. Yes. What else goes with it?
Side of fries, Jordan.
There's no catch. There's no catch, and and I'm well paid for this job.
Dr. Maruszweski, can you share another fun story of when you were doing surgery, maybe something you were able to save the day or something unexpected happened? You must have some great stories up your sleeve.
Stories like that I was thinking about sharing with you, but basically the overall idea is that let me start with this story, okay? Well, by my profession, I do very invasive medicine to my patients, and this is something I'd like to build on what Raphael said. And in many occasions, I speak to my patients and I tell them something that sounds potentially impolite. I said, I wish we never meet again, okay? Because next time we meet, okay, it's going to be something. But now it's not my call anymore when I send you home. It's for you to take care of yourself, because it's the last warning and the last meeting. And this is something I'd like to point out today. And one more thing. Again, this is another example. When the patient is being discharged and then it needs to be readmitted, it's not an issue. It's just being readmitted.
And you're saying in America that is a big issue?
Well, this is a big issue if the patient comes back within 30 days after discharge.
That affects the amount of money that the hospital gets to keep through insurance, correct?
Yes.
Okay.
Yes, which is not a factor in Poland.
So what's the case?
Can I add one thing to that?
Yeah, but
That,
can you? Okay, go ahead.
It's elaborating on that. It might tie to your question. Who knows? But I think obviously we in the United States we have the highest rate of next to, not to throw Germany under the bus, but next to Germany we have the highest rate of preventable admissions in the world, and mostly it's for cardiovascular related stuff. That's one of the highest areas you probably know, but see much lower rates in Poland. But because of that, we've had to put policies in place. So CMS, who's the Center for Medicare and Medicaid Services, has created policies that penalize hospitals for readmissions within 30 days, as Doctor mentioned. And so that has actually been a huge driver. Like they hire whole FTE, like people that were on my teams and other people in quality to try to prevent that from happening through very, very specific intervention. So we know it's a problem. It is a problem. The point is it's a much bigger problem than anywhere else. But it all goes back to prevention. Because if you prevent stuff, it prevents costs, not to mention keeping people healthy. Sounds like grandma apple pie, but we have to do that if we're going to save costs and save whole health systems. Yeah, it's really important.
Just a final example.
She does, but so what happens in that if you go back in 30 days exactly? Like, can you simplify it? Like, does the hospital not get any money from the insurance? Does the person not be able to collect from the insurance company? What happens?
So that's a great question. So those of you that might be in the payer world specifically might know more than me, but the essence of it is that you have a contract with CMS for all of your Medicare patients who are, so CMS covers the elderly and put simply the low income, often that have other health conditions as well. That's called Medicaid. In California, it's Medi-Cal. So just quick 101, Medicare is covering all of the 65 plus. So that's a hugely expensive population, particularly Medicare, especially with the growing number of baby boomers, right? And so hospitals have contracts to make a certain amount of money from Medicare, but they won't get all of it. They'll be penalized as far as the payments that they're contracted to receive if they do have X number of readmissions within 30 days. And they take a tally of that at periodic intervals of time. So you lose money. And hospitals have counted on that money not to be lost in their budget. So it's a big deal, especially for a lot of patients if they break the rule.
Anything else about Europe and America?
Well, I would like to build on this penalization system. In contrast to that, in Poland, which is located, 7,000 miles away from here, and is a relatively small country, We have just introduced a new law, which is the Quality Assurance of Healthcare Law, which basically incentivizes those hospitals who have the lowest admission rates within 30 days. So we are receiving extra money from the insurance for having great results and great outcomes that the patients do not come back. But if they come back, that's okay. That's still being covered. We are just being rewarded for providing high quality services. And I think it's like bringing up a child. You can either use the positive discipline, or you can stick and say you are not allowed to do that. Okay? Well, I don't want to give you the answer what's best. I think you know yourselves.
Yeah, we know what's best, the European model, but that's we're stuck here. We are going to do questions in a sec, but I do have some more questions. In terms of medical technology, what's being developed, what you've seen, what are you really excited about that we may not know about that you would, like in each one of you, you know, if you got one or two examples.
What does the future look like?
Raphael, you first.
Okay, and I don't want it to look like a plug for companies, but I'm privileged to be advising and helping out a few companies that I think are really, really high potential companies. There's a lot of innovation in the space. I don't know them all, so but what I want to do is just share the ones that I know and that I think are really interesting. First thing, I think in mental health, and that became a bigger and bigger issue with COVID and the pandemic. There are a couple of companies working on what's called brain stimulation to treat depression, which are phenomenal. So there's one that come out of Stanford called Magnus Medical, and they are actually able to treat patients with major depressive disorders who have been suffering with suicidal thoughts for decades and tried medications, and they tried speech therapy, and they can get them into remission in 5 days with a 90% success rate. I think that this is phenomenal. There's another one for milder depressions that right now is only in Europe called Flow. What's interesting with Flow is that it's a headset that they ship to your home that you actually put on your head yourself. You use it in your home, and also use mild brain stimulation to improve the depression. And treat the depression. So I think mental health, a lot of innovation with just energy as medicine or electricity as medicine. We see that in sleep as well. There's STEAM Science is working on a way to treat insomnia with electricity as medicine, so you don't have to use meds. I'll give you just a little laundry list of stuff I'm excited if you're okay with that in the interest of time. So we were talking about telemedicine, right? And actually enabling more services in the home using better sensors. There's more and more non-invasive blood glucose monitoring. You probably all know the patch that's got a needle, but I've seen, and I can't talk about it anymore, but I've seen that done non-invasively in a smartwatch where you can do continuous glucose monitoring, and you can do blood pressure monitoring on your wrist, non-invasively. That is absolutely game-changing. Blood pressure monitoring, it's Actia. It's a company that's based in Switzerland. That's doing really, really well. There are a few more players. And then I'll give you like an oddball. You might have thought about orthodontics. But do you know when was the last innovation in orthodontics? Fixing teeth is important.
I'm going to guess 50 years ago. I feel like they've been doing teeth the same way they've been doing back in the 50s. The only thing they've replaced is they no longer use mercury for the fillings, right? That's the biggest advancement.
I hope so too. You have the braces Align technology also that came out of Stanford with Invisalign. Everyone knows Invisalign. That was invented about 25 years ago. They have 15% of the market, and they're valued at $30 billion, right? $30 billion market cap. And there's a new company I'm helping out called InBrace. It's really interesting. They put the braces on the inside of the teeth, and then they use, it's mass customization. They actually custom shape a nitinol wire. That's what they use to make stents as well. Those nitinol wires are super elastic, and they custom shape them for your teeth, and then they connect that wire to the brackets, the braces, and that wire moves your teeth automatically. which is great because it's invisible for the patient and it's less work for the ortho. So it's another, some of those cool technologies out there. Can talk.
No, those were all great examples. Dominique, you probably get to see some really cool companies. What are you seeing at Founders Institute, the Health Accelerator?
Yeah, first of all, I just wanted to say, look out Invisalign. Like, they better watch out. Yeah, there's a lot of really great examples, and that was a great foundation, I think, for some of the great ideas out there. So one area I'm really excited about is therapeutic digital prescriptions. So what that means is that doctors now have the ability to prescribe certain digital therapies, as we call them, not a pill or a surgery or in the traditional sense, but in the digital healthcare space. And so there's a couple of companies, I won't mention the names, partly because I don't remember them. But one of them is a company that's actually looking at PTSD, and it's helping to use sensors to actually trigger different parts of your nerve endings when you're having bad dreams. And so it can actually detect that and actually intervene in bad dreams, which I read that and I was kind of like, oh my God, do I want that? But there are a lot of companies giving a lot of thought. And the beauty is that these are actually proven, effective, safe solutions that have been approved by the FDA, authorized by the FDA, whether they go through pre-approval or just the clearance phase. So that's one. And there's also just in the mental health, I just want to riff off that because the mental health space, I think, and I've read, is doing better than a lot of other areas just out of necessity. So you ask what's different after COVID. Mental health therapies, whether traditional or digitally driven, have just exploded since the pandemic because so many people sadly, tragically suffered, including from depression. And not even necessarily like bad depression, but just everyday anxiety and depression. And so a lot of digital solutions are using AI, to address that. And there's companies that I'm especially excited about the products that can be prescribed because I think they're given more validation by physicians and by patients if they're coming from kind of that level of authority. But prescribed or not, there's a lot of really cool solutions out there. I'll give a couple more examples. A friend of mine that actually graduated from the Founder Institute, which is the global Accelerator pre-seed program that I'm involved in, he created a digital robot it's a robot pill. And so some of you may have heard of these robot pills, but your average citizen has not, of any country. But you swallow this pill and it's diagnostic and it goes into your stomach and it has cameras and it can take pictures of what's going on inside your gut. And so that can help diagnose, which brings me to another example. There's businesses out there like GE that used to just do, what we think of as light bulbs and GE stuff. They moved into healthcare a couple decades ago, right? Long time ago. I've been seeing them at healthcare conferences and the exhibition booths for a long time. One thing they're doing is partnering with organizations and universities to do digital imaging of radiology images and health-related images that can guide surgeons and others, but really niched. So with Vanderbilt, they're developing treatment tools, partnering with Vanderbilt in that case, who has the clinical research pathology kind of data. But then when you put that together with GE and the imaging function and combine that with AI, you have all of these data that can not only help figure out what the best treatment option is, because you just have more data points to inform your decision, but can also drive predictive modeling where you can look ahead and predict what's going to happen with populations. So that's what excites me, is when there's multi-sectoral work and collaboration, that you couldn't have the same results without that collaboration from research and from business, not to mention from healthcare.
That in conjunction with some psilocybin, I imagine could have a pretty big impact as well.
That's a very California ad, Nick, but yes.
Probably. Dr. Marcin, you've worked on some really cool stuff with the Untitled Kingdom around pain mitigation. Can you share a little bit about this?
Yes. I'd like to share with you three perspectives on this issue. And the first one is the surgeon's perspective. The difference between the surgeon and its patient is that I don't feel the pain that my patient feels after what I do. And basically this opens the area of pain management as a whole. 50 million Americans suffer from chronic pain, which is defined as the pain that lasts over 3 weeks and doesn't go off. And this pain cannot be mitigated by pharmacology because the development of pharmacological solutions in terms of painkillers has stopped 20 years ago. The last discovery was opioids. 180,000 people die in this country because of opioid overuse. So we are absolutely in the wrong pathway here, talking about the differences between the countries. So what I'm aiming at is I do believe that only technological solutions can help us control pain in humans. Because in many situations, this pain is not associated with a direct disease. It's the process of recovery, is the process of some long-term injury that is not actively needs to be treated. So this is one area that we are looking at United Kingdom. But this is not the only area I think that is very important. Because I try to think, like we discussed with Dominique before, I try to think a little bit globally, thinking what is the universal problem that should be solved. And one of those areas is Femtech, which is looking at medical technological solutions for females. We have a lot of issues with menopause. I mean, let's face it, statistically, half of the human population is female. All of them, I mean, just a raw assumption, right? The surgical assumption, right? All of this population will go through the menopause. The average length of menopause is over 3 years. And it is not a disease. It is just a number of symptoms that makes this life a hell, not only for a woman, but also for the man who lives with her. So looking at the Femtech is the need for both genders, right? And this is one, but this is the second example. The last example will be a little bit combination in what we are discovering with Peter at Untitled Kingdom, but also from the scientific point of view. When we look at the human knowledge, I can clearly say what I know. I'm a surgeon, I know how to operate on a heart. When I get on the plane and the pilot gets sick, I know how to treat him, but I also know what I don't know. I don't know how to steer this plane or how to land it, right? I can clearly define that I'm not the pilot. I can just try to resuscitate him so he gets back and keeps on flying, right? But there is this area of knowledge which is I don't know what I don't know. And I had this great pleasure with Peter to meet a Polish girl who has a double PhD, one in physics, the other in astronomy. And she calls her an astrophysicist. But because of this obvious knowledge of the physicist, she actually spoke to me and she told me, well, what is ear? Raphael, what is ear? Ear is a transducer. What does it mean in English? A transducer is the place that the signal can be transmitted both ways. So we shouldn't look at the ear only as the microphone of the outside world transmitting the signal to the brain, but we should also look at the ear as the speaker that can tell us what is going on inside. And she told us that most of the current earbuds and hearing aids are equipped with noise reduction technologies. How do you do noise reduction? You put a microphone inside and you listen for the noise. Now, if you change the frequency, and this is what we don't know, and you listen to the signal below 20 hertz, which is something unheard of to human ear, you can hear sounds. Now the question is, what does it mean? The astrophysicist knows that because she's been listening to aliens coming from the space, so she knows that there are some signals that we just need to interpret. And I was completely amazed because this is something I didn't know.
So what does the inside of an ear sound like?
Well, she can hear something and she can already assign those signals to heart rate, blood pressure, heart pump function. She can hear the murmurs inside the ear. Can you imagine the situation overhearing yourself with the use of the regular earbud or the hearing aid? just an example. What I feel goosebumps when I hear about such a discovery, because this is obvious. This is there.
Well, we could continue. Oh, did you want to?
I was going to build on that. I think what's interesting is that when you get these kind of sensors and you're able to collect a lot of information data, then the name of the game is what do you do with it and how do you make sense of it? And that's where a lot of the machine learning and generative AI is going to be able to help make sense of these vast amount of data that we can collect. For instance, if we have this technology in every earbud and people were willing to let, to let someone collect all the data, we could get phenomenal insights into our health, but we need to be able to process the data, make sense of it, and that's why I think we're now getting technologically capable to do that thanks to machine learning, AI, and these very powerful tools and large language models, absolutely.
Well, we could continue all night. This is just fascinating stuff. But we did want to turn this over to the audience, as I'm sure they have some wonderful questions, too. So my lovely wife, Sandra, back here, will pass the microphone around.
Do I stand up? Oh, hello. I love this. This is music to my ears. This is collaboration at its best. So I have a gazillion questions, but I know that there's a lot of other questions here. Looking at Europe, Dr. Eminem, right? Eminem, that's your initial. Those are your initials. Would you say that in comparison to the U.S., what we've noticed, one of the main complaints that I hear is that there's not the collaboration with care, communication between specialists, and so would you say that Europe has that down, or is there a model in another country that has that as an example that we could look at? And then I do have a commentary before you answer that question. As far as looking at mental health, that is the key, because we do know that mental health is one of the major root cause with physical manifestation of disease, right? So I think looking at that, and I'm a retired toxicologist, so I do know a little bit about pharmacological, advancements, and we're going to see a very huge, sorry, I'm like shaking, decline in the amount of pharmaceuticals and an increase in quantum energy with healing. So anyway, back to you with that answer. Thank you.
Well, this is pretty challenging, and I don't want to sound too bold. Yes, because the healthcare system is moving very quickly, it's extremely demanding to really make that interaction and exchange of information between different specialists, and this is the challenge we face as well. And there is no fairy tale solution for that, absolutely. I do believe that, for example, with our European model of financing the healthcare, which is the single-payer system, it's a little bit much easier, because it can be required by the single payer. It's not yet in law, it's not yet required by law, but it can easily be regulated because basically it's a monopolic system. And this is the advantage of monopoly. When the single payer says, hey, you guys need to communicate, you guys need to exchange the information, you guys need to exchange the data. To some extent, we already have that in Poland, because most of the electronic health records are being stored by the Ministry of Health. So in theory, I do have access. When the patient comes and sees me, I do have access to all his medical history in the public healthcare system. I can see that through. I can see all the specialists he's been seen by. I can see all the prescriptions he's been given because of the e-prescriptions that have been introduced over COVID. So basically, and the patient has the look inside of that too. So if we make a mistake and we assign the treatment to a different person, things can be cleared up quickly. So yes, to some extent we already have that in place, but obviously I think there is a lot of to work on that. It's a work in progress, but we are getting there because we can afford with the single payer system to have those data being collected because everybody reports to the same payer.
Yeah, I just wanted to add one thing that, I'll answer your question to Dr. MM from earlier, from the United States point of view. We have one of the things that I think is more complicated that makes it much more difficult to have a coordinated system is that we live in a country that has many, many more stakeholders involved in the healthcare ecosystem, the payers only being one. We have manufacturers and suppliers. We have third parties. We have pharmacy benefit managers. We have data software and analytics, and we have awesome startups, right, that are trying to break into it. But the point is, it's much harder to coordinate. But yeah, we're more complicated from a governmental point of view, and it's just the way it just is what it is. But out of that complication actually comes some really good efforts from the government. So I'm going to throw the government a bone for a second. There's something called the Office of the National Coordinator, which my colleagues probably know. It's in DC, and they're an organization whose job, and most of you probably haven't even heard of it, but they do a lot of work, if you work in health policy, you know, in passing regulations and trying to kind of monitor what's going on to address things like coordination and privacy and all of the big, hairy problems we have in our US healthcare system, because it's the US healthcare system. And so, in particular, the example I'll give you is they have recently created a chance to be kind of known as an exchange data organization, and to basically have the ability and the authority to exchange and see health information from across many different systems. So said more simply, it's the incentivization of organizations like health information organizations or Kaiser Permanentes to share information across the ecosystem, across all of America. And so why does that matter? Well, it matters because patients get to see more of their information across different places, but more importantly, frankly, providers and coordinators can coordinate care as patients move from organization to organization, or even just as simple as they go to another state for vacation and they need health care. So this is huge in healthcare, that there is this step to share data, because when you share data, you share care processes. When you share care processes, you actually get to provide higher quality, more efficient, ultimately lower cost care. So it's a big deal, and it's all rooted in interoperability, which is the ability for systems to understand data from each other. So we're not all different nationalities going to one country and nobody speaks the language. Built into that is the requirement to be interoperable. So that's really big. We're doing some things kind of right.
Hi there. For the purpose of health and longevity, if you could wave a wand and make everyone wear a device that measures one signal, or let's say one related group of signals, whether it's a glucose monitor or heart rate or activity, what would, from each of you, what would that signal that you would most like to see and would have the biggest impact for the healthcare system, if you could wave a wand and just make it so?
That's a good question.
Well, I give you the obvious answer, because from my perspective, it's the blood pressure that I would like to see, because of the frequency of the fact that most of it is age-related, and it's correlated with some other follow-up and other complications like a stroke, a heart attack, and stuff like that. If I were to choose one, but I'm answering only because you've asked this question this way, because otherwise I wouldn't say that a single information is sufficient, right? But yes, I think from my perspective, it's the blood pressure that really stresses me out a lot, and it's also associated with the fact that we have a lot of emotions right now. We have a lot of non-covered emotional and mental issues, which are also associated with the way our cardiovascular system behaves. So it's not only controlling the heart muscle and the arteries, but it's also about seeing what is going on in terms of our mind, in terms of our emotions. So that's, if I were to choose, but I really would like to refrain from that and saying this is not the holy grail of the telemedicine and healthcare monitoring, absolutely.
And if I can build on that, because I'm with you, if it's very hard to get all the information you really want out of just one biomarker. Another one I would throw out there, just because it's going to happen sooner than we think, is tracking cortisol, for instance. What some people call is a master hormone, which is, it fluctuates very quickly. So you need to be able to actually monitor it at a high enough frequency that you can see the fluctuations for it to be helpful. You can't just do it once a day. Even once an hour may not be enough. But that's coming. And the day we start monitoring hormones and how they're changing on a minute by minute, for instance, we're going to get incredible insights into our health. Another one, so blood pressure, absolutely. I think another one that's interesting is not just one biomarker, but if you can monitor, and that's possible today, if you can monitor your brain, your heart, and your lungs, right? So think about, EEG you can do with a headband. With an ECG, you can actually do heart, and with bioimpedance from the sensors, you can also do respiration. And if you start looking, and that's where if you marry that with AI, it's interesting. If you actually start establishing a baseline of your health at night, because at night your system is active but kind of shuts down, and you start looking at how your heart, your brain, and your lungs work together. And if you start picking up on some disturbances or discrepancies, they may be early indicators that something's going to happen, right? Chronic disease or some sort of something bad that you could potentially intervene early on to prevent it. So there's just a lot we can do with medical grade sensors, and the technology today is cheaper than ever and easier to wear than ever. So it's quite exciting.
Can I add just really, really quick? Because it's a really good question. We could also do a whole separate one of these just on that question, because it has a lot of layers. But I'd say glucose, just because type 2 diabetes, and now I'm wearing my public health hat, but my colleagues know this too, diabetes type 2 is rising at such a rate that it's really alarming, and that's part of one of the areas that a lot of hospital and healthcare systems focus on, value-based quality metrics, is lowering your hemoglobin A1C. That's always been the case, but now the rates are really rising because of a lot of behavioral factors. So I'd say glucose, but being able to monitor that for everyone, regardless of whether they have access to a healthcare system, their income, their knowledge, their education, if you could just automatically measure that from birth, and it's just part of what you can measure, that would be amazing, I think, for public health in general.
We're going to do 2 more questions. So one is already in the back.
We got deep.
And you guys, give shorter answers.
Hi.
Go ahead, Deep.
This is really fascinating. Fascinating panel. Having spent time in Europe and having seen that you can get a lot of healthcare taken care of at the local pharmacist, which almost acts like a physician assistant in a way. And it seems like you can address many health issues before they become critical. Given that perspective, especially in France, here in the U.S. versus in Europe, what do you see as the emerging opportunities in healthcare innovation? What are some of the exciting things that you folks see? Because you're all at the forefront of this, including talking to this double PhD woman who has the ear thing that can sense what's going on in the head. I'm just curious, what can you share with us, and what do we not know that we don't know as an audience that you could help us know?
To be one positive side of the U.S. now. So I want to return. Well, from the regulatory perspective, even though I myself am a member of the European Commission Medical Device Regulation Committee, I must admit that please remember that all the medical devices and all the medical startups have another hurdle from normal or regular startups. They go under supervision and regulation and regulatory approval before they can sell. So from that perspective, FDA is much more agile in getting approval, even though it says clearly that it's safety and efficacy, what is supposed to supervise. Getting FDA clearance as of today is much easier to put your device on the market. Then getting the MDR clearance, and maybe because I am such a pain in whatever, but yes, it is much more stricter in Europe right now to have the CE mark than to get FDA clearance. So this is a great opportunity in the US to start, launch, and get clearance and get on the huge market, which is US, plus Switzerland.
This is our last question, everybody. But these 3 will be here afterwards. We just don't want to drag it out.
So whole body MRI scans for people who aren't sick are now affordable, not free or cheap, but affordable. And I experimented with getting a few, and my regular doctor said, I won't look at the results. There was no symptoms. Interesting. But there's been a lot of controversy about whether or not it makes sense to do that kind of proactive stuff. So please give me your comments about that if you would.
I think this is the preventative medicine that you were talking about, isn't it? I mean, this is what we should all be doing. This is the concierge boutique medicine that the wealthiest people in the world do all the time. They're getting full body MRI scans every year, right?
So I think we need to strike a balance, and this is going to sound, well, you decide what you think of this. There needs to be a balance in order for us to maintain the two goals of patient, I'll say individual engagement, and being proactive and knowing as much as you can about your personal health. And my master's was in health education, so I totally get it. I want to know as much as I possibly can before I'm telling other people stuff. But there has to be, in my opinion, and I think from a policy perspective, I'll say realistically, there has to be a balance between that and what health systems create as policies for what they're going to provide beyond the standard of care. So I know the standard of care is like, oh, moan groan, but a lot of systems are providing a lot of preventative services like Kaiser's, but also Sutter Health and a lot of other great systems around the world. So there actually is a lot of budget now, more than ever before, in preventative services. But unfortunately, health systems, I think, don't really have the budget always to provide everything that we want, which is often very legitimate, but there has to be somebody kind of deciding what's affordable and within budget so that they can take care of everybody's basic needs. Hot topic.
We were told to speak shortly, so I'll try to do it briefly. Well, there are basically two ways you can try to address it. Another example from Switzerland. Not in all Switzerland, but some insurers in Switzerland advise patients each time, the first time you get in contact with healthcare system this year, you are prescribed a full body CT or an MRI. Just because you have come to the system, not because there are no symptoms. Something must have brought you to the system. If you come, we'll screen you. If you don't come, that really means you have no symptoms. But no offense, again, my rusty English, this is old-fashioned way. I think we should basically look more at remote patient monitoring to be able to seek signals from the body without taking such a great effort. I mean, even looking from the eco-friendly situation, you know how much energy an MRI machine takes? We can do it with smaller devices. I mean, Raphael can give us example how much energy does his device take. And I think we can do it a little bit more eco-friendly and basically monitor our healthcare and status over, remotely, easily, without taking any, yes. Thank you.
I think if I can just add one more thought for you all to think about that, it has to do with liability. Because I played with that. I said, hey, I want to get an MRI scan of my brain. I want to see my brain, just because why not? It's cheap. And then I want to see my heart, right? And I want to see my whole body. But I talked to some very, very sophisticated Stanford professors about that and said, here's the thing, Raph. We can do that. The challenge is, what if we find something that maybe would never have been an issue in the first place because it might be benign, because it doesn't matter. It may be something that would take 200 years to develop and it's not an issue. But now that we have it, we have to do something about it. And just a biopsy might do more harm than good. And so, because from a liability standpoint, they have to act on it. And the question, the balance becomes, how much information do you really want to know? That's information that actually you want to know early enough because something bad could be prevented. But if you really look, you'll find something, and maybe you're better off not finding it in the first place because of the way the healthcare system is structured and the liability that you're putting on the providers with that information.
All right, what a fantastic panel. Let's give them a quick round of applause here. Yeah, go ahead. Thank you, everybody, for joining. Check out Primera Negocios and the Codex as well. And be sure to tune in next time for more of the best brains from the Bay to beyond. Thank you so much, everybody. Take care.
Thank you. Excellent job. Thank you, thank you.
Nobody thought everything. What are you talking about?